All right. Hello, and thank you for joining the POCUS Certification Academy for today's Focus Bites webinar. My name is Daria, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is Introduction to Renal POCUS, and our speaker is Dr. Victor Rao. Victor is going to be here with us for Q&A, but we'll be sharing the presentation via recording due to some connection problems. So I will tell you a little bit more about Dr. Victor Rao. He's a radiologist by training and worked as a primary care physician before pursuing radiology. He's one of the pioneers to introduce POCUS to medical students and PA students at the University of South Carolina School of Medicine. He developed the POCUS curriculum and POCUS educational content for doctors and PA students at the USC School of Medicine. He also helped develop the e-learning YouTube content for USC School of Medicine, as well as develop the teaching content for Introduction to Point-of-Care Ultrasound CME programs at the USC School of Medicine. His passion is ultrasound and POCUS. He's also helped introduce POCUS at Arusha Lutheran Medical Center in Tanzania, the University of Santo Tomas in Manila, Philippines, and Haiti. He has authored and co-authored several ultrasound and high-intensity POCUS ultrasound articles published in peer-reviewed journals. He has also written several chapters in POCUS ultrasound textbooks, POCUS blog articles, and clinical cases. His goal is to teach POCUS and make it easy for every clinician to learn and practice POCUS safely and effectively. He has trained thousands of students and clinicians in hands-on point-of-care ultrasound. Dr. Victor Rao is also part of our team, and very happy to have him here today with us. Thank you, Dr. Rao, for joining us today, and I will go ahead and share the presentation.
Here we Hi everyone. This is Victor Rao. I'm a radiologist by training and also being an educator and being able to train medical students and PA students and residents, medical residents in the point of care ultrasound. I would love to share my experience as a physician and as a radiologist, as well as an educator in the point of care renal ultrasound arena. So just to kind of let you know that it is an important skill to learn, and it's also relatively easy as compared to other organs, other organ systems inside the body. And keep in mind, it is a hands-on modality. Ultrasound is a hands-on modality. So my goal today is that you will have a higher level of confidence after listening to the lecture, and perhaps it will aid you in assisting or making a better clinical diagnosis in your patients. So without any further delay, let's start introduction to renal point-of-care ultrasound. So that was a very brief introduction about myself and the topic that I was covering. As you've noticed that I turned the video off so that my video is not overlapping some sections of the slides that are coming. So basically today we're going to be covering the objectives for today. The topics are going to be broadly the anatomy of the urinary system, which would involve the kidneys, the ureters, and the bladder. Some common indications, ultrasound tips and techniques, how to perform an ultrasound, also how to calculate the bladder volume manually or using an ultrasound system with an inbuilt calculation package. And lastly, we will cover some commonly encountered urinary system pathologies that you may see in the point of care setting. Keep in mind that uh, we can only cover so much today, because as I started this, I was trying to be very ambitious, and I realized that there's only so much I can do. So I picked some important topics, conditions that would be of great interest to anyone who's performing a renal or urinary system evaluation using point of care ultrasound. So now we're going to talk a little bit about the anatomy. As you know, the kidneys are retroperitoneal structures, and the kidneys are surprisingly, they're mobile. So if you have a patient take a deep breath, forced inspiration expiration, you can actually make the kidneys move 6 to 8 centimeters. In This is reported in one study on both sides. And kidneys are paired structures, so you see you have a left and right kidney. uh, the length is about range of 10 to 12 centimeters, and they're roughly at the level of T12 to L3. Upper pole is slightly medially oriented and also posteriorly as compared to the lower pole. This is the upper, this is the lower pole. And the right kidney is slightly caudal as compared to the left, because we have the liver on the right side. So in this slide, we have the sectional anatomy. You must be wondering, why are we talking about sectional anatomy? That is going to be really important, because when we do the ultrasound of the kidneys, we should be able to figure out the different structures and what they represent. So we have on this side, we have the hilum of the kidney, and of course the vessels are not shown. We'll have the renal artery and the vein over here, and we have the renal pelvis. This section is the pelvis, and then we have the major calyx. We have the major calyces, and then the smaller ones are the minor calyces. They join together and drain the urine that's being formed over here into the calyceal system, and from here it goes to the renal pelvis, and if there is no obstruction, it will go to the pelvic junction and go down the ureter into the bladder. Here we have the medulla, or the renal pyramids. We have the cortex. This is, and outside the cortex, not shown, but there is actually a renal capsule. And in some patients, we may be able to also appreciate some perinephric fat. Here is the renal column, which is actually a tissue that is in between the two adjacent medulla. In this slide, we're going to be looking at the ultrasound anatomy. So here we have, this is obviously the right side because we see the liver. And look how you compare the liver ecotexture to that of the renal parenchyma or the cortex. And as you can see, it's kind of similar looking, and that's what it should be. And then we have, of course, this white, thin white line is representing the capsule. This is the cortex over here. And this is dark areas are the medulla. And this bright inner center area is the renal sinus of pelvis, because we don't see any fluid, just a little bit of fluid perhaps over here, but not too much, because the patient does not have hydronephrosis. And so that's how the kidney lies inside. And posterior to that is the psoas muscle. So sometime when you don't have kidney present in the normal location, you will see the psoas muscle, and of course behind that is going to be the spine. So make sure you don't identify or misidentify the psoas muscle as being the kidney. It almost looks like it, but don't be tricked. Here we see again the similar view. We have the right kidney, longitudinal view, and you can actually see the kidney here and observe that it's kind of similar, as I mentioned earlier. The renal cortex or the parenchyma is almost similar in echogenicity as compared to the normal liver. Normal, not abnormal liver. So it's either isoechoic or similar in ecotexture, echogenicity as compared to the normal liver, or could be slightly less as compared to the liver. And we see the medulla, which are those dark areas. Those are the medulla. Why are they dark? Because they have more fluid in them. Anything that has more fluid, where remember the glomeruli are filtering and making the urine, and it's coming through this area into the renal sinus, pelvis. And then we have this is known as corticomedullary differentiation. That means you can differentiate the medulla from the cortex. If you are unable to see that, that means there is probably something going on with that kidney that is not normal. So that would perhaps even suggest the patient may have chronic kidney disease. So this is very helpful, especially on a point of care setting. Patient, first time you're seeing a patient, you put the probe there, and you're like, whoa, this kidney is definitely looking very abnormal. And it's very bright, and there's no corticomedullary differentiation. I'm going to show you a slide about that. And then, of course, if you look at the echogenicity scale, we have the renal sinus, which is bright, or the pelvis, and then we have the cortex, which is this area, and then we have the medulla, which are the dark areas. So that's how it should appear on ultrasound in a normal patient. The renal pelvis will appear like this, bright and because it's got fat and blood vessels in it. But if you have a renal pelvis that is dilated, is full of urine, then it will appear anechoic, because fluid will allow the urine to blood, so the ultrasound beam to pass through the urine, and without any significant attenuation or loss or signal, also no reflection. So as a result of that, it would appear anechoic. And normal parenchymal thickness in adult kidney is about 15 millimeter. Why it's important? Because if this number is low, that this thickness is less, that means patient has some form of kidney disease. So if you remember, I was talking about normal liver, not abnormal liver. Here we have a kidney, and we see the liver next to it, and this is your Morrison's pouch. But there's a problem with the liver. The liver is very bright, echogenic, very hyperechoic. It is in the phase called the fatty liver. It's not that advanced because you still see a bunch of blood vessels and ducts through the liver, and also we're able to see the diaphragm clearly, because in advanced fatty liver you would not be able to appreciate the diaphragm, and a lot of attenuation of some beam is going to occur. So as a result of that, you will see this area will be very dark comparatively as compared to the one that's closer to the ultrasound transducer. But look at the sharp contrast. Suddenly we see a very bright looking liver and a relatively dark looking kidney. And so right away, of course, there's no renal pathology here, but we do see that this patient has fatty liver. So we've been talking about a non-appearance of the kidney, but what would happen if the patient had a chronic kidney disease? It's been long standing for several years perhaps. So we see something called as a small shrunken kidney. Kidney becomes smaller in size. Here you can see the distance, the kidney length is 8.3 centimeters, which should be 9 to 12. It can get even smaller. I remember one time we were doing biopsy on the patient, and the kidneys were so small and so shrunken and so hyperechoic that we could not even differentiate the kidney from the surrounding tissue. So it was a real challenge. So just to kind of let you know that it may become so hyperechoic that you may not even see the kidney. So what is relevance of this with point of care is that when you see a patient and you put the probe there and you see a kidney like this, you know right away that this patient has some form of kidney disease, and it's not acute, it is chronic. Look how the parenchyma has become so thin and echogenic. So you can see reduced renal cortical thickness. The cortex is less than 6 and in the normal situation it was 1.5 centimeters. Small shrunken kidney, reduced length, all dimensions are reduced, not just the length. And also it will be difficult to visualize the pyramids and the renal sinus, and you may also see some marginal calcification, some fabric calcification, and also some tiny cysts inside the kidney. Here are some the common KUB, kidney, ureter, and bladder ultrasound indications in the point of care setting. Of course, this is not the complete list, but it covers a bunch. We have flank pain, which is going to be quite common. Uh, Everybody would experience that or have a patient or encounter a patient who has or presents with back pain, abdomen pain, or flank pain. I remember there was a medical student, and he was saying that he's been having chronic back pain. It was on pain medication for several years. So we just scanned him, and I was shocked. He actually had a really large staghorn calculus in the kidney. That was the cause of the pain, and nothing to do with his back. And of course, took treatment, and his back pain was gone. You can have hematuria, dysuria, oliguria, urinary tract obstruction, urinary retention, or evaluate the grade of grade hydronephrosis, UTI, recurrent UTI or UTI, acute pyelonephritis, renal abscess, trauma, renal mass, bladder wall inflammation. That's done a lot. Some outpatient setting, and in patient that you might suspect BPH, or somebody who was post-op or in the ward wanting to get a catheter in. You want to make sure that they have enough urine in there, because sometimes patient has cystitis and they may want to feel that they want to go to the restroom, and they will request catheterization, but there is no, so we would not want to catheterize unless we have a significant amount of urine in there, and of course urinary incontinence. Here's a brief introduction to the developmental process of the kidneys. As you know, the kidneys develop in the pelvic region at about 5 weeks, and then they ascend up, and sometimes this process can get disrupted, and the kidneys may not ascend all the way, or one kidney ascends, other one stays there, stays as the pelvic kidney, or they can fuse and cross over. A lot of different combinations of anomalies are there. This is kind of important to know so that we can rationalize or understand if we do see something. If we don't see the kidneys in the normal location, clearly the patient does have kidneys, because adult patient can't survive without kidneys. Okay, there has to be one kidney at least. And now if it's not a normal location, then we have to kind of try to find it. Either it could be uh, a horseshoe kidney, or it could be a pelvic kidney, ectopic, someplace else. So we have to do this hunt to figure that out. It could be renal agenesis on one side, which also I happened to see in one of our or actually he was a resident, and it was really shocking, and he was totally unaware of it. In this particular case, you can see that the patient has no kidney on the left side. You just see the spleen. You should have seen the kidney somewhere here. It's absent left kidney. It's an adult patient, so there must be another kidney. And sure enough, patient has a right kidney. And what happens in these cases is that the only kidney that's present, is doing the job of two kidneys. So essentially, it undergoes some sort of compensatory hypertrophy. And you can see it's a really large kidney right here. And so what happens, the kidney is so large, it's extending below the rib cage. So we should advise these individuals to avoid contact sport, because they will get injury easily. In fact, this particular case, you can see the patient actually has a hematoma over here in the kidney, and a small blood clot present right over here. So there is also a condition that we should be aware of, is known as Potter syndrome. It's essentially bilateral renal agenesis. So obviously it's incompatible with life. Most of these babies are born, infants will die within 24 to 48 hours. 33% of these actually die in utero, and it's incompatible with life because there's no fluid during development process, so they undergo pulmonary hyperplasia, and of course there'll be severe oligohydramnios or ahydramnios. That means no fluid seen. It's going to be all crushed in there inside the uterine cavity. Keep in mind with this to make sure for renal agenesis or unilateral renal agenesis, make sure it's not cross ectopia, ectopic or pelvic kidney. So there are some other variants which I think you should be aware, because you don't want to be alarmed and say, oh, what is that? So here we have is a dual collecting system. You can see very bright echogenic renal sinus, which is normal. You will encounter a bunch of patients like these. This is just a normal variant and you don't have to do anything. This is showing like a little mass over here on the left kidneys, and only seen on the left side in some individuals. And according to NH data, the incidence is about 0.2 to 2.0%. And this is known as a dromedary hump. And you may also see things like bifid ureter or duplication of the blood vessels. You may have, 2 or 3 renal arteries supplying the kidney. Those sorts of things you may encounter, but it's not of much significance. So these, do not consider these as pathology. This is normal, and you should be aware of this fact. The next condition that we should be aware of is known as horseshoe kidney, and incidence is quite high. It's 1 in 500. I've seen 4 to 5 medical students who have horseshoe kidney running around, and they were first year medical students. They came in and they were very open to lie down on the table to act as volunteers to be scanned, and we were shocked. They didn't have normal kidneys. The students are like, they don't have kidneys. I said kidney got to be there. And when we scanned, we found actually there was a mass, a complex mass like this, sitting right across the spine, and you can see the spine, vertebral body. We see the posterior shadowing. We can even see the spinal canal over here, that through which the spinal cord is passing, and we see the aorta and IVC, and of course we see this little mass kind of thing, which is essentially the kidney. It's a horseshoe kidney is fused together. And what is the problem? These normally we don't do anything about them, but just be aware. Same thing, avoid contact sports because high risk of injury. Second thing is that they have a high risk of developing renal stones or renal calculi, and also they develop, some of these individuals will develop transitional cell carcinoma of the renal pelvis. So here are some very basic tips and techniques for performing a good point of care ultrasound of the urinary system. Make sure the patient is fasting. Avoid beverages or carbonated drinks like Coca-Cola, Pepsi. Just kind of drink that because the bowel gas is gonna. And try to do the exam early in the morning or the first thing in the morning. They can take sips of water if necessary. They have to hold the urine. The bladder should be distended, but not over distended. If it's over distended, that's going to hamper the imaging and also might give a fake impression, a false impression or conclusion of hydronephrosis because they will be backing up. It's a closed system. And then the patient will scan the supine position. If you are having some difficulties, you may also do left or right lateral decubitus position. If you suspect a stone and you're not so sure about it, or you want to double confirm, you can use color Doppler, which will elicit the twinkle artifact. And that is really a great way of confirming the stone. I have an image I'm going to show you guys. And then do not hesitate to perform a repeat scan, and if ever in doubt of some lesions, do send the patient to radiology, because sometimes they may want to evaluate this patient and do further tests even CAT scan at times to figure out what's going on. Here's a simple diagram kind of showing the probe position. So patients who are lying supine, we scan from uh, the right and the left side, aiming a probe towards the kidney area, and we can scan from the anterior, mid to posterior axillary line, and same on the other side. And for the bladder, we're going to perform suprapubic scans. Make sure that you scan both in the longitudinal and transverse planes, and also make sure that you go beyond the kidney. Once you stop seeing the kidney, go beyond 3 to 4 centimeters past the margin or capsule of the kidney, because there may be something lying just next to the kidney, so we don't want to miss that. And also obtain both the transverse and longitudinal views. Never perform just one view. That is going to be a mistake, and you may end up missing an important diagnosis. So here we have same view that I showed you earlier on the right side, to just for everyone to kind of understand on the same page. This is a long axis view of the kidney. Make sure when you're looking at the kidney or imaging it, make sure your cortex, the renal cortex, this little gray kind of band around hypoechoic area, is seen uniformly around. If you're not seeing it here, then you got to angulate your probe or tilt a little bit to kind of get it perfectly on all around like that. And then you measure from upper pole to the lower pole. Remember, the probe marker was pointing cephalad, so this is corresponding to the probe marker. And so this is cephalad, here is cephalad, and this is caudal, and this is anterior, this is posterior. And you can see it's 10.3 centimeters, which is within the normal range. On the other hand, we have on this side, we have the transverse view. You can see a renal vessel coming in. We can see the renal sinus. There's no hydronephrosis. And you can see the renal capsule, and you measure anterior, posterior, and width of the kidney. And in this view, we have, since the probe marker is pointing to the patient's right side, so this is the right lateral side of the patient. This is the towards the midline. This is medial. This is anterior. This is posterior. So the normal ureters, as you can see in this diagram, are running from the renal pelvic region and go all the way down, travel all the way down parallel to the spine right here, and then enter into the bladder. And the normal size is approximately 3 millimeters. So it's hard to see a ureter unless it's dilated. And that's really when we are concerned about it. If there's a pathology, of obstruction to flow of urine, there's a mass, or there's a tumor pressing on it, or even the patient could be pregnant, advanced pregnancy, putting pressure on that ureter may cause it to dilate. So, but be aware that when you have a stone passing through in the ureter, there are 3 common sites where the stone will get obstructed, which are the natural barriers or natural narrow points. So one is going to be the pelvic junction, or over here, and the second one is going to be the lobe where it inserts into the bladder, and that is going to be your uretero vesical junction, UVJ. And then third one is where it crosses across the pelvic brim as it enters the pelvic cavity, and it crosses over anterior to the common iliac arteries, just before the artery kind of divides into the external and internal iliac arteries. Here we have 2 views. On the left we have the transverse view of the bladder, which is obtained with the probe marker point patient's right side, and we scan through the entire bladder, and so in the mid region where the bladder appears to be nice and wide like that, that's where we're going to freeze it. This is anterior, this is posterior. You can even see this is a male patient. We can see very faint trace of the seminal vesicles. If it was a female patient, we would have seen the uterus or the vagina and vaginal stripe. And over here we have the right side. This is the left side patient. And this is a mid-longitudinal view. You can see anterior, and this is cephalad region of the bladder, and this is the posterior region. You can see the prostate over here. And as you know, in this particular slide, we can see a good example of something called as ureteric jet. It is obviously very dramatic, and you can see the color. The way this works is you look at the color legend, and it's telling you red and yellow are going to represent flow towards the transducer. Here's your transducer. Flow towards it will be red and yellow, and that's what we're going to expect. If it was going the other way, it would be blue and light blue. Then what does black represent? Black represents no flow. What about red? Red flow toward transducer, but not that fast. If it is yellow, that means it's a very fast flow. So it's kind of just a general idea about, it's not any number, but it's giving you a very relative idea of the flow, how fast it is. But it's more quantitative than, and it's not more qualitative than quantitative. It's not telling you the speed, it's just telling you relative the direction, and also giving some idea about how fast it is. 1 to 3 jets in a well hydrated patient. That is very important. You may have a patient came in to us. We saw the patient, and the patient was typical complaining of ureteric colic, and we expected that, but there was no hydronephrosis. There was no ureteric jet. So then we hydrated the patient, and of course we saw the jet coming from the other side, but the side that had obstruction, there was no jet anymore, not seen. And so we conclude the patient has obstruction. Now you see hydroureter, and make sure to confirm a diagnosis. If you're not seeing a dilated ureter or the pelvic lymph system, then you hydrate the patient, make them drink water, or maybe start on IV fluids, and then perhaps you will see. So that is important. It's a well hydrated patient. You should get 1 to 3 jets with normal renal function. If they have renal failure, they may not have that, or they may have very faint jets. So these jets are just not interesting to look at. They actually have a message for us. And sometimes we've seen it that the jet may be even seen without the color Doppler using B mode. And yeah, that's because urine may be concentrated, and urine may have some cast and send evidence. I have an image coming up, and perhaps we'll show you that. So here we have a technique showing you how to obtain the mid-transverse view and mid-longitudinal view of the bladder, and then how to measure. So we basically measure inner wall to inner wall over here transversely, and then anterior posterior, and then cephalad to caudal. So this is given 3 dimensions. You note these in centimeter. Here you can see, and then you multiply all the 3, and then you multiply that by a correction factor, which is 0.523. The ultrasound manufacturers, some of them, they actually use this number as a correction factor to determine the volume of the urine inside the bladder. This formula actually can be used for anything that has a similar shape to kind of determine the volume of that lesion, or if it's a fluid collection, you can use that. And there are some systems that have a software built into it that when you select volume calculation and you calculate these 3, it's going to automatically determine the volume and display it on the screen for you. So remember that why would you even want to do the bladder volume estimation is to evaluate a patient with anuria or urinary retention, patient who comes for evaluation of bladder volume for catheter insertion. Patient may feel that they need to go to the restroom, and when you calculate the volume, you look at it and you're like, oh, it's only 30 cc. You don't want to put a catheter in for 30 cc because every time, even though we follow the strictest protocols and stringent hygiene, there is still, or disinfection and everything that you do, there's still a chance of introducing a bug into the patient's bladder. So we want to avoid that scenario unless it is really essential. And then post-evaluation, patient is sedated and they can't, so we want to avoid bladder damage. If there's prolonged sedation, then we want to put a catheter in. And of course, suspected BPH, and keep in mind the true post-void residual urine is actually zero, and we've done that under fluoroscopy. We actually put a contrast into the patient's bladder, and then we ask the patient to micturate while performing fluoroscopy, and we saw that the volume was zero in normal conditions. But why would you give a range of 0 to 20? Because by the time the patient goes to restroom, comes back, and by the time we put the patient back on the table and we scan, some time may have elapsed, and as a result of that there may be some, because urine doesn't stop forming. It's always urine is being formed in normal patients and it's coming down the ureter into the bladder, so we may have some urine in there. I think it's normal to expect. If you think you spend a lot of time, then perhaps you can go to 30 to 40 cc's, but keep in mind the actual true post-void residual urine is actually zero. But we kind of give that range. I'm more comfortable with this number, and because if you have residual urine in there, that can actually be a cause of recurrent UTI, urinary tract infection. So now, with this basic background knowledge, we can now try to look at some cases that you may encounter in the point of care setting, and we will go over the findings so that you're kind of comfortable and familiar with it. In ultrasound, remember, it's all about pattern recognition. I would recommend that you guys, all of you, try and do this. Google a bunch of images online, and also when you have a patient who has a report with the urinary system, check out those images or scan the patient, send the patient for evaluation by radiology, and when the patient comes back, see that did you come to the same diagnosis or not. So those sort of things are really going to help you. Here is an example of a patient, normal looking kidney, very little bit slight dilatation of the you know the real sign pelvis, but it's really not significant. But what is remarkable here, the patient actually has a very tiny calculus, and these are very small and does not even cast a very significant, maybe a very faint shadow is here, very slight shadowing. So don't expect a deep shadow or dark, dense shadow with a small calculus. Even calculus smaller than 2 to 3 millimeter may not even cast a shadow. And in this situation, if you are in doubt, turn the light of the room a little bit low, dark scan condition, and turn your gain low a little bit so it's kind of looking dark and it's going to shine like a star in the night. And use color Doppler, and it's going to elicit the twinkle artifact, which will make your job very easy, and you will be able to confirm that this indeed is actually a real calculus. Here is an example of a very beautiful case, and you can see that the patient, we can see the bladder, and we can see the ureter, and we can also see the opening of the ureter here, and you can see there's a small calculus inside. I kind of highlighted it so it shows you the lumen of the ureter, and of course the small calculus that's in there. It's difficult to follow these down, but when the ureter is dilated, it will become easy. So just kind of follow it with your transducer. Make sure your transducer is exactly cutting through the ureter as you slowly move the probe down, slide the probe towards the bladder, and just follow it all the way down, and you should be able to see. But normally, as I said earlier, they will get impacted over here. This is so you will see some form of edema over here. Here is another beautiful case, and really highlights the value of even X-ray. You can see X-ray of the abdomen, the pelvic region. You can see these small densities over here, you know. But the problem is we don't know what is this. I mean, is it a phlebolith or is it because there are a bunch of them? There's no way that all of these are going to be calculi within the ureter, because ureter is never going to go like that. So, but ultrasound is really helpful, and so here we have a beautiful image showing the ureter, and we have the bladder, and we see these three stones inside. And we turn the color Doppler on, and we see very beautiful colors like blue, yellow, green, all kind of colors in there. And this is known as the twinkle artifact. I mean, I'm pretty certain that you would agree with me that these are clearly stones inside the ureters. And of course, when I see this, I'm very, very certain that these indeed are the stones. And so it is a good confirmatory test. You can add color Doppler, and when you see the twinkle artifact like this, it is indeed a stone. So it will make you more confident in making your diagnosis. Here is another beautiful case. You can see patient's bladder. It's full of urine, not too distended, but enough urine in there. And you can see these are big echogenic calculi sitting inside the dependent region of the bladder, and of course you can see a dense acoustic shadow because they are much larger in size, about maybe a centimeter or more. So you have casting a nice acoustic shadowing over here. And if you did twinkle artifact with the color Doppler, that obviously would light up with the different colors and also confirm it again. It is a very interesting case that you may sometime encounter, and you can see clearly that the patient has, this is the bladder, urinary bladder, and you can see there's some sort of a connection, there's a pathway here, and this is the neck of a diverticulum, and there could be multiple diverticulum inside connecting to the bladder. And so we press the bladder with the probe, or ask the patient to kind of, you know, press down or act as if he's trying to put some pelvic pressure, and you may elicit this uh, the color flow as the urine moves from the bladder into the diverticulum. And you can see here, this is the color legend. So red is towards the transducer and blue is away. So there's the transducer here, and the flow is from the bladder into the diverticulum. As you're putting, just be sure, make sure not to put too much pressure, just a sudden gentle pressure. And you want the patient, don't scare the patient by just pressing, and the patient might wonder what's going on. So just tell, I'm going to put a little pressure, and just to see if there is any, you know, document the connectivity. I mean, it's very obvious it is connected here. So it's not essential, but if you do it, well, that's makes your evidence more confirmatory. Here is another case that the ultrasound is formed, perhaps in emergency setting. You can see the bladder here, and we can see a bright echogenic structure and a dense acoustic shadow, and that obviously is uh, a calculus inside the bladder. In a situation like this, unless it's emergency, we would actually ask the patient drink more water, distend the bladder a little bit more to be able to see it clearly, but it is clearly there. And we can also do the same thing, can use color Doppler to elicit twinkle artifact. One thing that you don't want to do is to put a catheter in and distend the bladder with saline and then scan, because now you are doing an intervention, you're kind of in is a procedure, and you may accidentally introduce some infection in there. So that is not an indication for that. I would avoid or definitely advise that that should not be done in any patient. Okay, this is a really interesting case. You see, somebody had submitted, a volunteer submitted this case, and as I was reviewing these images and videos, I saw something really interesting and tried to look at it with me. Do you see something happening over here? This is the kidney, and the patient has some form of hydronephrosis. You can see the pelvic floor system is dilated. But what's happening over here? So this patient happens to have a small calculus, and maybe there are two of them or more, but this particular calculus seems to jump up because ultrasound is pressure wave is passing through, it's shaking up things, and so the energy is pushing the stone back up a little bit. So there was a research study done in which they were trying to push stones using ultrasound and kind of make them travel down through the renal pelvis into the ureters so that they can be flushed downwards, and even use ultrasound to make the stones travel all the way down into the bladder. But it was kind of a difficult task. So theoretically it can be done, but it's going to be quite a challenge actually. But if you see something like this, you know what's happening. It's really the ultrasound beam is making the stone jump. So this is a very interesting slide. I think everybody should learn this, and no reason to be intimidated, because, and also be aware that radiology may have a different scoring system or grading system, and so keep in mind that it may not be consistent with this, but we are going to simply follow a simple way of grading this, and which is mild, moderate, and severe hydronephrosis. So renal ultrasound is really good in diagnosing hydronephrosis, and its sensitivity is 80 to 94%, specificity is 82 to 99%. So if you go back to our original diagram in anatomy, we have the ureter, we have the renal pelvis, and then pelvis is connected to the major calyx, and these small little horns, those are the minor calyces, and these are supposed to be concave in shape. But when you look at the normal kidney, if there is no backflow or outflow obstruction or any obstruction flow urine, then the renal sinus should appear echogenic. Here it doesn't, so we see a little bit of black area inside, or anechoic region inside that, and that is actually representing the fluid, which is the urine in there. So, but it's very minimal, and so this is mild hydronephrosis. You could create this situation by holding somebody's from passing urine, have a very distended bladder, or even a pregnant patient can appear like this. Next we have, on severity, we have the moderate hydronephrosis. So moderate, we will notice that, so here we have normal, this is mild, and then moderate. You see that the major and the minor calyces are dilated, you know, and when that happens, but one thing is very important to observe, that the renal parenchyma is preserved. But when you look at something like severe hydronephrosis, it's a little bit more of the dilatation, and it can get even worse to the sense that, to the extent that there may not be even a renal tissue present. I saw this patient who had long-standing severe hydronephrosis, and when we scanned the patient, we did not even find any renal parenchyma. It was just one large cyst like structure full of urine, and that was extreme, like grade 4, grade 5. But we are going to keep it for our perspective from a point of care point of view: mild, moderate, and severe. Severe is a little bit more obvious dilatation, and I have another case, and you look at that, and you see that in severe, you see the renal parenchyma is getting thinner. It's putting pressure on the renal cortex and the parenchyma, and as a result of that, there's atrophy and destruction of the renal parenchyma, and it gets thinner with time as more pressure builds up, more back pressure, more pressure coming up along, and so as a result of that, in the end, you will have nothing left of the renal tissue. So definitely want to catch this at this stage. That is the whole idea of doing point of care ultrasound, so that we avoid individuals advancing to moderate. And if you see someone with moderate, you need to let them know, and you have to make sure that you make the patient aware. And also, we don't want to let the patient go home. We want to manage and set up something with the patient so we relieve that obstruction. Otherwise, next time you see them, you won't even have a kidney that is functioning. And so keep in mind, the obstruction could be internal. There could be a mass or a stone inside. There could be external compression by lymph node or a mass or a tumor. Could be congenital, because kidneys could have some structure compressing it. The ureter being compressed by some structure, some band or tissue, or it could be that the kidneys undergoing nephrotosis, it kind of falls down and the patient stands up. As a result of that, there's kind of kinking happening over here. That would be a little bit more advanced diagnosis. We may want to use IVU or something else for that, but you can still figure it out with ultrasound. And of course, physiological state. You can create mild head nephrosis in yourself by actually, not going to the bathroom and holding urine and drinking 2 liters of water. Try it, and you'll be surprised you'll be able to see it like that. But this is kind of keep in mind that this is a really important topic, and but keep in mind that there's no uniform consensus on this, and so radiologists may use 0 to 4, 0 to 5. 5 or means that this renal parenchyma is extremely thin, it's destroyed completely, and it's basically telling you it's really, really bad. Here I've attempted to show you the progression. Patient has normal kidney. Look at the renal pelvis sinus. It's nice, bright and echogenic because the fat blood vessels that make it look like this. A little bit of fluid, that's okay. But then we have mild hydronephrosis. But look, it's not so dilated, and also it's kind of maintaining that concavity of your minor calyces. Now we go to moderate, and you see now it's kind of ballooned out, but the renal parenchyma still looks pretty decent. And here we have severe, in which see how dilated that looks. Some people call it the bear claw. And I have another image, I think the same image is something else, and a CT scan. I use CT scan, so sometimes ultrasound images may be hard to understand, and so it'll help you understand or grasp what's happening over here. But you can clearly tell this is normal, this is mild, just a little bit, this is moderate, but parenchyma is still good, and of course this is severe and can get even worse. It can become a really large cyst. That patient that I saw, oh my gosh, it was just a large cyst. I couldn't see any renal tissue. We also did IVU, and there was no absorption of the iodine in the kidney at all. It was a non-functioning kidney. I mean, it was just there. So those sorts of things you have to be aware of. And of course, prevent. We don't want anybody to progress to this. This is not good. Here we have another case, and to kind of make it interesting, I googled and I found this is the bear claw. Very dangerous looking, very sharp. And I saw some sort of a food item on Amazon which shows a bear. It's also called bear claw. It's almost like the bear claw has ripped through this bread piece or something. But anyway, here is it again, the severe hydronephrosis. And we look on this side, we can see the kidney. Look at this. This right kidney is nothing but one large giant cystic structure. And compare it with the left kidney. Look at the left kidney. Looks pretty decent, good uptake of the contrast. So this patient actually had a large calculus in the right pelvic ureteric junction. And as I told you, if you remember, there are three sites where these stones notoriously will get impacted because these are natural barriers. There are narrow points. The second one will be as it crosses through into the pelvic brim and crosses anterior to the um, common iliac artery on its left side, just before the common artery divides into the to the internal and external iliac arteries. And then further down, we go into the bladder area where the ureter is entering into the bladder. That's a uretrovesical junction, UVJ, and that's where it will get obstructed. Well, it doesn't mean it cannot get obstructed elsewhere. Of course, it can get obstructed anywhere, but those are going to be our hot spots. This is sometimes and most time actually going to be an incidental finding. They found that 40% of CD abdomen had incidental renal cysts. So most times these are going to be thin-walled. They could have irregular walls, or they could have septation or internal vascularity with the color Doppler or power Doppler. You can see some color in there, and that would suggest that it's possibly a complicated cyst. It could be a malignant cyst also. So be aware of that. And this one, do not confuse with the hydronephrosis. See, this is has a nice thin wall. It could be here too, but if it has a nice thin wall, that is parapelvic or pelvic cyst. So make sure you don't confuse cyst with hydronephrosis. They're two separate conditions. And we generally leave them alone because most of them are going to be asymptomatic incident findings. If we see something like internal structure, we see some mass inside and just some flow, that obviously is a dangerous sign and would warrant further investigation and follow up. And make sure you follow these patients because they may come back after 1 year and then they have advanced renal carcinoma. So keep in mind, some of the renal cell carcinoma may start like this. So we're talking about renal cell carcinoma, and we have, could be variable in appearance on ultrasound, could be solid or partially cystic. It could be hypoechoic, could be isoechoic, that means looking like the rest of the renal tissue, surrounding renal tissue, could be hyperechoic. So it's so variable, you can't say that what this lesion is, so you have to look at it very carefully. Hypoechoic, and also do follow any lesions that are very suspicious looking. And hypoechoic halo will be seen in 20%, so it's not a very much a sign that, but if you see a hypoechoic halo, like somebody's taken a black pen and drawn like a outline around it, that is highly suspicious. That may be a malignant lesion. And contrast enhanced ultrasound, I don't know if you guys do this, but heterogeneous hypervasculature, during arterial phase with early washout. That's just kind of by the way kind of thing, information that I'm providing you. So renal cell carcinoma is definitely must be picked up if you see, and you have two beautiful cases that I handpicked from non-net sources, thanks to these sources. And we have a well-defined irregular kind of mass in here in the lower pole of the kidney. This is renal cell carcinoma. It's got heterogeneous echo texture, and this is renal cell carcinoma. And we have another one. This is more or less is hyperechoic, but we see the other image on this side. This one is also kind of irregular looking, has these extensions like that. It is highly suspicious of malignancy. See how it's going like that. And again, this is hypoechoic, so it could be anything, and maybe has some cystic areas here, some little cystic areas. So This is a renal cell carcinoma, and again, we must do further investigation. We're not going to manage just with ultrasound, so we do a CAT scan, and we also do the biopsy. Biopsy will be the gold standard. So as we're looking at renal masses, we're looking at cysts. We saw some renal cell carcinoma, but then we also need to be aware that there are some benign conditions like renal angiomyolipoma, AMLs. Very well defined, hyperechoic, and is present in the kidney and may look very suspicious, but it essentially contains fat, smooth muscle, dysmorphic blood vessels. Is kind of bright, as you can see, very bright. But again, this is all relative, because if you had a patient with a chronic kidney disease, this kidney may be looking very bright and you may not even see the structure. So be aware of that. And most hyperechoic renal lesions measuring less than a centimeter. So if the diameter, we measure it diameter. If it's less than centimeter, we just do follow ultrasound and let the patient know we have a kind of a suspicious lesion, but perhaps it's just benign. And you want to seal follow-ups and make sure it's not growing. And then one study reported that 32% of the renal cell carcinoma up to 3 centimeter were hyperechoic and could mimic AMLs. So renal cell carcinoma could look like it, but these two particular cases were actually reported as renal angiomyolipomas. So I'm showing you these cases so you can get an idea as to what they are. So don't jump on the conclusion and say, oh, you have a renal cell carcinoma. No, this is, but I think your best bet is going to be following the diameter. If it's less than 1 centimeter in diameter in both axes, then unlikely that it's going to be something serious. So here are some final thoughts. I think urinary ultrasound, the point of care ultrasound, should be learned by all clinicians at some stage in their POCUS journey if they are pursuing learning point of care ultrasound and adding it to their skill set. They must learn it, because you will be able to quickly assess the patient's kidneys, ureters, and the bladder, and at least be able to figure out there's something going on over there. Keep in mind that ureters we don't see, but we will see them when they are dilated. So if they are dilated as hydroureter, then you will see them and you just follow it down. Then you scan both the kidneys in transverse and longitudinal planes and go 3 to 4 centimeters beyond the renal capsule. If you do not do that, you will definitely miss a lesion one day. Lesion could be in the suprarenal gland, adrenal glands, or they could be a cyst, pedunculated cyst, or there could be some mass of tumor there, or an abscess, or something going on. So make sure that you look beyond the kidney, because there are some lesions that are outside. And then scan in low lighting conditions. If you have bright lights in the room, there are chances that you will miss some lesions. So make sure the room is not too brightly lit. Turn the light off or have just a faraway light on, and make sure your gain is set low and be comfortable while you're scanning. The POCUS exam is actually a quick and easy way to assess the urinary system. I will tell you a good example here in personal life. I actually was on call and suddenly I started having some kind of vague abdominal pain. It became colicky, and I kind of knew right away I had a probe in my pocket, and I just scanned myself, and there it was. I saw I had hydronephrosis, mild, and then I was able to drink a lot of water, and then I followed the ureter down and I saw a small calculus in the ureter. So just trying to let you know that even in your own life, and even in your patients, you may complain or you suspect. And I remember that beautiful story of the true story of a medical student who was being treated for back pain for several years, and he did not have anything to do with the back. All his problems were because of a large staghorn calculus in his kidney. And once that was removed, all his pain symptoms went away and he was off pain medication. So be aware that, that is, I'm not saying all back patients are going to have renal stones, but we definitely want to make sure that we are not missing something. And also it's low cost as compared to CAT scan. There's no ionizing radiation. There is no nephrotoxic IV agents that are necessary. It's an excellent modality for initial assessment and also for follow-up, and again with a high sensitivity and specificity for calcium hydronephrosis. Just can't complain. This is a beautiful tool to have and great skill to know.
All right, thank you so much, Vic. This was a lot of good information. So I know we are a little bit over, but I still wanted to cover some of the questions from the audience. So Vic, if you want to turn on your camera, thank you so much. We can go. Before we do so, we have a couple of cases for you guys to present and to see if what Vic presented was helpful. So I'll start with our first quiz. You should be seeing on the screen the image and then a couple of answers. So please feel free to respond to the question and let us know what you think. We'll give another maybe 30 seconds. I see 40 people responded out of 111 that we have online. So take your time and see what do you think? All right, we have 55% of people answer, so another 10 seconds maybe. All right. I'm gonna end the poll and share the results. Vic, do you want to comment on this case?
Yes, this is a very interesting case. Can you guys hear me? Right?
Yes. We can hear
Okay,
you.
so are you able to fill up the answer so it'll be easier because I kind of have a labeled answer, but if not, we can just address it.
Yeah,
But it
you
shows,
can't see the answer.
I just see the question. It's okay. So basically, you see the bladder, and you can see a small outpouching and the connection there, and so that is the bladder with a small diverticulum. So, and if you look very carefully, you can also see something else in there. Don't get too excited. You see there is a little echogenic structure inside the verticulum, and that happened to be a calculus inside. You can demonstrate it's calculus and not a mass or a polyp. You can just have the patient roll around left lateral, upright, or lateral, right lateral position, and that thing did move. So it's really a nice way to determine the true nature of it.
All right, I think 68% got it right, so we'll move to the next one.
This is a tricky one, so I apologize, but I want to make it tough for everybody so that you don't get tricked again.
All right, here's the case for you guys. We have small case with 3 answers, so take your time. Let us know what you think. Okay, I see 53 out of 109 people responded. So give another maybe 10 seconds for everyone to catch up. All right. Let's see the results. And we have the correct answer is bladder calculus, not impacted, freely mobile. Unfortunately, more people answered the second answer, renal calculus impacted in the right ureter. So Vic, do you want to comment why this would be the case?
Yes, so in this case, how we solve this, if you see echogenic calculus inside the bladder, as I said, sometimes it's difficult, and to confirm it, you want to roll the patient. So left lateral supine, right lateral, and you will be seeing that it does roll. So if you watch those two images, you know that the position of the stone has changed. And that's how we can actually even do it while scanning, have the patient roll, you will see the mobility. The stone will be rolling down to the dependent area. So that's how we kind of, confirm this. And you could have also done color Doppler that would show the twinkle artifact.
Right. We have a couple of more. Here's the image was obtained while scanning the kidney. What is the diagnosis? So have a couple of answers for you and let us know what you think.
Daria, the answers are hidden. So maybe you may want to move that image a little bit.
You can scroll down. I see people are answering.
Oh, they're doing okay, awesome. Yes, I see.
44, 45 out of 100. So we have maybe another 20 seconds left. Let's see what we have. Okay, I think we kind of slowed down, so I will end the poll and share the results. And most of you answered correctly. Vic, do you want to add anything?
Yes, so I'm glad that everybody figured this out. This is definitely not mild because you see very prominent dilatation of the pelvic ileal system, and it's full of urine. And what is really going to help us? No, definitely moderate. But how can we say it's not severe? Because we see the renal parenchyma is still preserved. And that is really how we figured. If the parenchyma is very thin, say 2-3 millimeter, 5 millimeter, then it's a severe case, severe hydronephrosis. So it's very much within normal range, of very close to normal. And so, yes, so this is good job, guys. And this is actually moderate hydronephrosis. Thank you.
Thank you. Right, I do have the last question for you guys. If you can submit your feedback for us, we would really appreciate it. And let us know if this presentation was helpful. And while you guys are doing this, we can move to our Q&A where we can answer a couple of questions. Thank you for sticking around with us. Vic, as always, has a great amount of knowledge to share. So the presentation ran a little bit over, but I know Vic can go for a second hour if we have to. So let's start with the first question. How do you choose the orientation of the angle correction cursor in the power Doppler mode, and what is the orientation of the gate?
Yeah, keep in mind that we would like to keep our correction angle less than 60 degrees because there is an error that comes in with this. So for nephrology or for looking at kidneys, flow in the kidney, we want to actually have it like 30 degrees or 20 degrees even, so that would be kind of angle. But in general, let's say you're doing the carotids, we want the angle correction cursor to be parallel to the flow. So if you kind of see the blood vessel and kind of keep it parallel to the vessel walls and parallel to the flow. And then you use technique like heel toe maneuver. So basically imagine this end of the probe is your heel, And this is the toe. You just dig in into the patient's subcutaneous tissue to get the right angulation. And HOB is 60 or less. And for nephrology, for renal system, we want it to be kind of close to 20, 30 degrees, because the more the angle, definitely not more than 60. So to be, because otherwise the error generated is going to be much more. The reason for that, the calculation formula has cosine theta. Theta is the angle that is formed, and cosine 60 is 0.5. So we definitely don't want to go more than that, because it will be erroneous. The value will be of no good, no use.
Thank you. And before we move to the next question, there was about 8 answered questions that you guys submitted early in the presentation, and Vic went ahead and responded to some of it and typed the answers to save some time. So feel free to read on those answers. So we'll go to the next one. What is the physics behind the twinkle artifact?
The twinkle artifact is really interesting, and you basically see multiple colors, and there's a lot of controversy even as of now. But remember that, where else do we see something similar? If you have a patient with a severe stenosis of, say, carotid artery or renal artery stenosis, you will see not twinkle artifact, but you see aliasing occurring, and it's like multiple colors, and it's a very high velocity. But it's kind of similar. There's nothing flowing here. But in this case, there's some sort of a system jitter or phase jitter, or inherent ultrasound system noise that is causing this. So that's really, but again, I don't want to worry too much about why is it really happening. It's good to know, but there is still a controversy. So what is more important is that if I see the twinkle artifact on same thing that I think is a stone, especially a small one, I'm very confident this is actually a renal calculus. So that's what we need to remember, not to worry too much about the physics of it. But definitely you can dig deeper, and you will find a lot of interesting answers when you try to research in this topic.
Thank you. Next, thank you for your comments about the presentation, Peter. Moving on, in indicated patients, if kidney size is borderline 8 centimeters, can we still attempt biopsy?
So again, where is that question on here?
Yes, if you scroll down, we have a question from Sai Harisha Kanala. So the question is,
if the kidney size is borderline 8 centimeter, can we? Of course, we can do it. And as I told you, there was this patient that we had much smaller kidney and chronic renal failure. They were trying to drum something. So I was working with the urologist to kind of do a biopsy. And so, yeah, you can definitely do it. But keep in mind, sometimes these will be very tricky because you may not be able to see it well. So, but ultrasound is a great modality, and I love the fact that, but in that situation, we actually also used, at the same time, we used fluoroscopy and all kind of things, to kind of be sure where things were. So yes, you can do the biopsy, definitely can. Yeah.
Thank you. I think we're gonna pause here. I know we went over a lot of time, so I want to be respectful of everyone, but if you want to email us your questions, we'll take time and respond to them via email. Again, thank you so much for taking the time today, enjoying our presentation. Vic, thank you so much for taking the time to record the presentation, and this was recorded, so please make sure to check back on the recording in a week. You'll receive an email with instruction on how to access the recording, and this will also be posted on our website. I also wanted to remind that this is a copyrighted material by the Academy, so we do not allow making recordings on your own. I saw in the chat earlier someone mentioned that, or making transcripts. So please make sure you do not distribute anything or do not make any recordings. Thank you so much. Really appreciate your time, and hopefully we'll see you next month. Thank you.
I would like to apologize to everyone because I was so passionate about it, and I really had a lot more things to share. So
I think that's
It
great.
didn't be on my time, but the goal is that, you benefited from this presentation and you'll be able to use it in your clinical practice. Thank you so much.
Definitely, Vic. I think everyone understands, and I see people already asking for more presentations like that. So we'll definitely have Vic back talking about any additional topics, or we'll bring this topic maybe more advanced. So definitely sign up for our newsletter, check out our social media. We're always posting new content, and then hopefully we'll see you soon. Thank you so much. Have a wonderful day or morning, whatever you are. We'll see you next time. Thank you.
Thank you, everyone. Bye-bye.
Bye.